everyone. Welcome to Objectives 48 to 51. In this set of notes, PowerPoints, and our audio, we're going to talk about cardiac regulation and blood pressure. We spent some time last week on reviewing the heart anatomy, and then talking about the cardiac cycle, all the changes, pressure, and timing changes that the heart goes through in order to actually pump the blood in one complete heartbeat, one complete cycle. We did touch a tiny bit on blood and blood pressure, so we're going to just take that information a little bit farther with this outline. One of the first things we want to do is we want to define some really important terms and look at a really important formula. The first is cardiac output. Cardiac output is the amount of blood that's pumped out of all the ventricles, both right and left, in 1 minute. Cardiac output usually is about 5 liters of blood, which is our total blood volume. So all of your blood gets pumped out of the heart every single minute. If you remember from our last week's lecture, we talked about stroke volume a little. And stroke volume is the amount of blood that's pumped out of the ventricle with every heartbeat. So that if you simply multiply stroke volume times how many beats per minute, or your heart rate, then that's how we actually find cardiac output. So this formula is going to be really important for us to keep in mind the entire way through. We're also going to see how we can work with this. So again, heart rate, maybe that's 70 times per minute at rest. Your stroke volume, how much blood is pumped out of the ventricles every heartbeat. Multiply those together and you simply get how much blood is pumped out of those ventricles every minute. And again, that's about 5 liters. Something interesting I would think about cardiac output is how much it can really increase when you're exercising. For most of us, it could increase up to about 20 liters per minute when we're exercising, but a well-trained athlete can actually have such an efficiency. They can actually get up to as many as 35 liters per minute during exercise. Note that also some interesting things about these graphs is how heart rate can alter as well. Look at how heart rate is lower actually during exercise in a trained athlete and in an untrained person, the average Joe. Okay, probably one of us. So what that means is, remember, we can store a lot of oxygen in our muscles. That cardiovascular health allows our heart rate to be lower and our cardiac output to be higher. So what does some of this control of our heart rate, what controls our heart rate and thus our cardiac output? And most of that control is an area of the brain called the medullary cardiovascular center. I would say it's the most important extrinsic control on the heart. Of course, we know that the intrinsic control on the heart is that cardiac conduction system, that inherent ability for heart muscle cells to beat on their own and then using their own pacemaker cells to control the rate and rhythm. But extrinsically, we remember that the autonomic nervous system, again governed by the medullary cardiovascular system, that center, autonomic, sympathetic, and parasympathetic, is what we call the accelerators and the brakes. That's kind of an external system that can increase or decrease our heart rate, and that increase or decrease, you see, is then going to have a major effect on stroke volume and cardiac output. So again, what happens if we do activate that parasympathetic nervous system? Those are considered to be kind of the brakes, and those brakes will slow down your heart rate. That slowing of the heart rate is going to make your cardiac output less by using this formula. On the other hand, if we remember in the autonomic nervous system, the sympathetic can do two things. It not only can increase your heart rate, it can also increase force of contraction, which would increase your stroke volume. By that twofold mark, both of those parameters would increase, kind of really showing an increase in cardiac output. So our autonomic nervous system, as regulated by that medullary cardiovascular center, the medulla and the hypothalamus, really can be the brakes and the accelerator for our cardiac output. We know, and I'm sure that you remember, but I wanted to review this just in case. We know that the sympathetic nervous system can be activated by any kind of emotional or physical stress. So fear, stress, anxiety, being really happy, even exercising. Those sympathetic fibers use epinephrine and norepinephrine as their neurotransmitter, and we recall binding to the beta-1 adrenergic receptors that are in the heart. And by binding here, we do remember that it does increase the heart rate as well as the contractility or the force of contraction. So again, sympathetic can have a twofold effect on cardiac output. Parasympathetically, now that's the alternative. If you remember, this was our rest and digest system. And the parasympathetic uses acetylcholine as its neurotransmitter, which actually hyperpolarizes those membranes in the cardiac muscle cells. It actually opens potassium channels. So by doing that, parasympathetic can lower our heart rate, actually lower blood pressure, lowers our respiration rates. But you see, it has that single parameter change here. Parasympathetic affects our heart rate, it lowers it, and by doing so would, and that should be a negative, would lower our heart rate. The parasympathetic, interestingly, is actually always active. It inhibits our SA node. That acetylcholine binds to muscarinic receptors and inhibits the SA node. We mentioned this before, but I wanted to bring it up again because it's so fascinating to me. Your SA node naturally wants to, of course, be the pacemaker, but it wants to beat, depolarize your heart at about 100 beats per minute. That's awfully fast resting, and that would really tire your heart, overwork your heart over time. So your vagus nerve is the parasympathetic nerve, which is going to deliver that acetylcholine to the muscarinic receptors. The vagus nerve is always active, so it actually inhibits the SA node so that we can slow down a bit to 70 beats per minute all the time. So when we activate that sympathetic, not only do we have to activate the sympathetic, we have to actively inhibit the parasympathetic in order to increase our heart rate. So remember that they work together. On one hand, if you activate sympathetic, you must inhibit parasympathetic, and vice versa. So each division opposes each other, and that's what actually keeps our heart in that homeostatic balance. This is one of my favorite pictures because it does a lot of reminding for us. The parasympathetic uses our vagus nerves, it releases acetylcholine to the muscarinic receptors, and this is kind of where you might find that SA node. On the other hand, our sympathetic nervous system uses thoracic spinal nerves to deliver our epinephrine and norepinephrine, which will bind to the beta adrenergic, which not only increases the rate, but also the contractility. The next thing we want to do is take a look at other parameters, other variables that can have an effect on heart rate and therefore on cardiac output. So I thought we might take a look at pressure receptors, your limbic system, how body temperature can affect it, as well as various ions, both increases and decreases can have an effect on your heart rate and thus cardiac output. So the first one we're going to take a look at is a baroreceptor. If you don't know, if you can't remember, baroreceptors are pressure receptors. They monitor pressure changes in our blood vessels. And so any change in systemic blood pressure could have an effect on heart rate. Okay? And so what we're going to find, and we're going to work with this quite a bit, is that, for example, we might increase blood volume. That would increase blood pressure. If we're increasing blood pressure, that would have an effect on heart rate. Your heart rate alone, if you're exercising, for example, if it were to increase, that would affect your blood pressure as well. And we also know that cardiac output is an increase in cardiac output is the amount of blood that's pumped into the aorta. And so that would probably be an increase in pressure against those vessel walls. So you can see how these really do relate, that blood pressure, heart rate, blood pressure, cardiac output, blood pressure, blood volume, even changes in blood vessels like increased blood viscosity, increased peripheral resistance, like how many blood vessels you have, all of those would affect blood pressure. And we're going to learn, especially when we talk about this a little bit later in the audio, blood pressure and cardiac output and heart rate really go hand in hand. Let's talk about those other areas like your temperature, your limbic system, which is your emotional center of your brain, and then the various ions. All of which, of course, can have an effect on your heart rate. Your limbic system, like I mentioned, is your emotional center. It's actually white matter in the brain that does help us to either be excited and happy or depressed and sad. And it can affect different divisions of the autonomic nervous system. And as such, if it's affecting the autonomic nervous system, then that's going to have an effect on your heart rate. So, for example, if a limbic system would be activated during depressive or grief situations, this would indicate a stimulation of the parasympathetic division. And we already know that the parasympathetic decreases our heart rate. On the other hand, if you're showing excitement, elation, fear, any of those emotions, the limbic system would activate the sympathetic division, and that would increase your heart rate. So your emotional state affects your heart rate. Your body temperature affects your heart rate. Let's just use one variable. We'll talk about an increase in heart rate. If you had an increase in heart rate, that increases your heart rate. Did I say heart rate? Sorry. If you had an increase in body temperature, that would increase your heart rate, because what it does is it enhances the metabolic rate of your cardiac cells, their use of oxygen, their production of energy. Cold, actually, if we wanted to go the other way, has the opposite effect. It would decrease your heart rate. Cold has an ability to lower our metabolic rate, lower our use of oxygen, lower the production of energy, lower the enzymatic reactions that would take place in our body. So it really, really, really slows us down. Probably why surgical rooms are so darn cold. Gives them more time to work. Taking a look at the ions, various charged particles that would have an effect on heart rate as well, we want to take a look at calcium, we'll take a look at sodium and potassium. These different electrolytes need to be in homeostatic balance at all times, because if we had increases or decreases, that can really affect the contractility of a muscle cell. As we know that these sodium, potassium, very important for the depolarization, and calcium, absolutely important for example, neurotransmitter release, and for release of that troponin, tropomyosin sliding effect theory. So taking a look at calcium first, we know that if you had a lower amount of calcium, that's called hypocalcemia, that would depress the heart and depress heart rate. We know that calcium, when it is too high, that would be called hypercalcemia. We remember that calcium is, again, very, very tightly coupled to that excitation-contraction mechanism. And so if you had too much of it, it actually elongates, prolongs the action potential, which increases heart cell irritability and results in spastic contractions. So too much calcium affects the heart, making spastic contractions. Too little calcium depresses the heart and its rate. Sodium, we know, of course, very important for that depolarization reaction. Sodium has to enter the cell, potassium has to leave the cell in order to alter the polarity across the membrane, change the polarity across the membrane, and create that spark of electricity, which is our action potential. If we had too much sodium, it's called a condition called hypernatremia. That actually blocks the transport of calcium into our cardiac muscle cells. And that means low calcium, that means we're blocking heart contraction, so we're depressing the heart once again. So too much sodium is not good for the heart. Let's talk about too much potassium, a condition called hyperkalemia. This interferes with depolarization mechanisms. This makes it impossible for us to depolarize the cell membrane because it would already be too positive outside that cell. And again, that will be very severe. This could lead to a condition called heart block and, worst case, cardiac arrest. One way to stop the heart, inject potassium. That'll get you immediate cardiac arrest. One more chemical that I thought we might take a look at as it relates to heart rate and then cardiac output will be thyroxine. And we've seen thyroxine before. This is thyroid hormone released from the thyroid gland. We know that thyroxine increases our metabolic activity. It increases the heart rate's use of oxygen, or the heart cell's use of oxygen. It actually enhances or triggers epinephrine, norepinephrine. So all of these effects would definitely increase our heart rate. So you can see again, thyroxine increasing sympathetic, increasing epinephrine in blood, increasing contractility of the heart, increasing end systolic volume, increasing that heart rate as well as stroke volume. All of these things are going to help us to increase that cardiac output. But one of the things I wanted to kind of make sure I brought up is that thyroxine is a hormone. And so it's not as fast to bring about its response like a neurotransmitter would. It has a much more slow release, slower effect, but it's more sustained. For example, did you know that thyroxine is more prevalent in the body in the winter months? Because it's cold, we need to increase that heart rate, increase that production of heat. And so I always say the best time to go on a diet is in the winter when your thyroxine levels are really high. Okay, we're going to change up just a touch. We're going to keep using what we know, but I told you that blood pressure, heart rate, cardiac output, they're so related. And so in this objective, we're going to talk about blood pressure instead, but still using what we know of cardiac output, all so that we can help to understand how to regulate our blood pressure. Remember that blood pressure is that pressure against the walls of your arteries, as well as the walls of your arterioles. So it's just that pushing of the blood against the vessel wall. Now, we can measure that pressure. We can talk about that pressure being normal, too high, too low, and some of the pathologies that might be related. But we also want to understand where that pressure is coming from. So this is a super important formula as well. I want you to memorize this, as well as our cardiac output formula of stroke volume times heart rate. Memorize this as well. Blood pressure equals cardiac output times resistance. And let's talk about that. So we know that cardiac output is the amount of blood that's pumped out of the ventricles every single minute. So the more blood that's forced into a vessel, the higher the pressure against that vessel wall. And we already know that heart rate is involved. The higher the heart rate, the higher the cardiac output, so the higher the pressure. Same with stroke volume. The higher the stroke volume, the higher the cardiac output, the higher the blood pressure. So you can start to see how all of these different parameters are related. Here's a new one though. What is resistance, also called total peripheral resistance or TPR? Resistance is opposition to flow. It's the amount of friction that blood encounters as it passes through the vessels. So the actual opening of a vessel is called the lumen. So the smaller the lumen, the increased resistance, or the larger the lumen, the decreased resistance. I like to look at it this way. Imagine this is a river, and all this water is flowing through the center. And the water that flows through the center goes very fast. But any water that hits up against the bank goes a little slower because it's meeting the bank, it's meeting up with friction. So the more bank we encounter, the more friction, the more opposition to flow. If you oppose flow, that actually increases the pressure. So increased resistance also increases your blood pressure. And there are a couple of ways we could increase resistance. We could have more blood in there. We could have longer vessels, that's a longer river and a lot more bank to meet up with. We could have vasoconstriction. Vasoconstriction will be a really, really small lumen for all that blood. And so it will be a huge pressure in there. Think about your garden hose when you turn that nozzle really, really narrow and how the water shoots across your yard to water your yard and your neighbors. That's a vasoconstriction, and that really increases that pressure. So blood pressure, we know, is created by the blood inside those vessels, or the fluid, and it's driven by the heart as a pump. So any kind of fluid within a closed system driven by a pump would create a pressure. So the closer you are to the pump, the higher the pressure. So what are going to have the highest pressures? Arteries or veins? Arteries, totally, you're exactly right. Veins, because they are technically the farthest distance from the heart. And I understand, superior vena cava, but that's right next to the heart. Yes, but if you think about it being a loop, you begin at the heart and you end at that superior vena cava, that's the farthest distance you can get away from the heart. And so the blood pressure in your superior vena cava is 0. Veins, very low, 20 millimeters of mercury, capillaries as well. Look at your aorta. That's a pretty darn high pressure because that's the first vessel that we pump all that blood into during stroke volume. A couple important things I just want to make sure we go over as we take a look at all the different indicators, measures, regulators of blood pressure. Just wanted to bring these few pictures up. That remember that blood is under the highest pressure in the arteries, but the arteries are designed for that. They have really thick muscular walls, and so they're designed to be under high pressure. We don't want the pressure, we don't want the blood flow, to be very high, very fast in a capillary, because we need that pressure to be high enough to drive the blood, but slow enough to allow for exchange to take place, get rid of that oxygen, take on that carbon dioxide. Blood pressure in our veins is very, very low, but again, we've planned for that. In your veins, of which you have twice as many veins as you have arteries. Remember vena comitantes, that you have 2 veins for every 1 artery. Those veins, you have twice as many, so a lot more ability to get that blood back to the heart. We know that there are valves inside those veins to prevent any backflow. We know that the lumen is much larger in a vein to reduce the friction. So we've done a few things to make sure that the veins, even under low pressure, are able to get that blood flow back to the heart. So how do we measure blood pressure? I would imagine many of you, because you're probably in the medical field, already know how to take a good blood pressure. So this may be just a bit of review for you, but just in case. Blood pressure is measured in millimeters of mercury. That's how all pressure is measured. And we have a formula where we put one pressure over the other. This is a very normal 120/80 blood pressure. That's putting our systolic pressure over our diastolic pressure. But what does that really mean? So up to here, your systolic blood pressure is the maximum arterial pressure that's reached during peak ventricular ejection. So our ejection phase. During ventricular ejection, we're pushing all of that blood from the ventricles into vessels like our pulmonary artery and our aorta. That aorta, for example, has the highest amount of pressure against it because that left ventricle wall is really, really, really thick and powerful. So we can measure that peak pressure at about 120. When your ventricles relax, we start to kind of recoil that blood, kind of relax that ventricular wall. There is still blood in the aorta, but now it's not being forced by ventricular contraction. And so that's actually called our minimum arterial pressure, and that's called diastolic. You could say that occurs either after ventricular ejection is complete or before ventricular ejection actually begins. And again, this is a ventricular relaxation phase, and it's usually around 70 to 80 millimeters of mercury. are a couple other parameters we just want to mention while we're here before we move on from blood pressure, and that's parameters called pulse pressure and mean arterial pressure. Pulse pressure can be measured if you take your systolic pressure minus your diastolic pressure. That's going to give you your pulse pressure. So if your systolic is 120 and your diastolic is 80, that would be about 40 millimeters of mercury, and that's an average pulse pressure. But what is it? It's actually that feeling, that pulsation, that throb in the arteries that you might actually palpate, that you might actually feel. That heartbeat, you're feeling the systole of the beat. Interestingly, they use pulse pressures in terms of measuring pathologies of our blood vessels. So I mentioned that the most important cause of an elevated pulse pressure would be stiffness in our aorta, which is, of course, remember, the largest artery in our body. That stiffness can be due to high blood pressure, fatty deposits damaging the walls of the arteries. That's called atherosclerosis, and even hardening of the arteries. That's called arteriosclerosis. You would notice an increased pulse pressure, which could be that first indicator that we better take a deeper look. Here's another parameter that we can actually use as well to measure some health, and that's called your mean arterial pressure, or your MAP. Mean arterial pressure is the arterial pressure, the average arterial pressure that takes place throughout an entire cycle of your heartbeat. We know that arterial pressure, like for example, aorta, that pressure in your aorta is constantly changing. There's high pressures and there's low pressures. There's high pressures and there's low pressures. Throughout your entire cardiac cycle, you might stand up, sit down, you might exercise, you might walk around, you might be excited. So your pressures can change quite a bit. So what we want to do is we want to, as an indicator of health, measure an average arterial pressure. And that's what MAP is. Mean arterial pressure is the average pressure. The thing is, it's not exactly average between systolic and diastolic. You can't just add them together and divide by 2, because our systole lasts longer than our diastole lasts longer than our systole. The heart spends more time in relaxation than it does in contraction. And so it's a little bit more of a complicated formula in order to get that average pressure over the cardiac cycle. And so it's simply this. I mean, it's not too hard. Your mean arterial pressure, you just take your diastolic pressure, again, which could be 80, and you add about 1/3 of your systolic minus your diastolic. So this should be, again, about 40. So 1/3 of 40 is about 15-ish, 13-ish. And then your diastolic pressure, again, would be about 70 to 80. And so this could be anywhere between like 82 to 95. Okay, and so that's what we're seeing here, that average pressure in the aorta. And so like in this example, that 85 would be a perfectly healthy average aortic pressure throughout the entire cardiac cycle. So I wanted to start with this picture because we're going to start with objectives 50 and 51, and this isn't really a very long and drawn out set of objectives, but it's basically this picture. It's everything that we can do to our body in any kind of situation that would have an effect on our cardiac output and therefore on our blood pressure. So this whole objective talks about if this raises, what happens to blood pressure? If this raises, what happens to cardiac output? If this decreases, what happens to heart rate? And so you can kind of take your time later on with this image and look at every different kind of parameter. For example, over here, increased renal activity, conservation of sodium. If you conserve sodium, that would increase your blood volume because water goes with it. If that increases your blood volume, how much blood returns back to the heart would increase, and that should increase both your end diastolic volume as well as your end systolic volume. And if those increase, and of course the amount of blood pumped out of your heart every minute or every beat would increase that stroke volume, and then that would of course increase your cardiac output. And we know that if cardiac output goes up, so does blood pressure. So you could kind of run through all of these scenarios at your own time and just kind of ask yourself, if something changes, what are all the different effects that you might see? Okay, so just take your time with this whenever you feel like it. But we're going to start talking about all the different ways that we could affect your blood pressure. So again, let's talk about those pressure receptors again. Remember that pressure receptors are receptors that respond to change in your blood pressure. Now, one thing we didn't talk about yet is where those blood pressure receptors are located. Most of them are located pretty high in the neck, right about here where that carotid artery will branch into its internal and external to supply the head both internally and externally. There's an area here called the carotid sinus, and that carotid sinus is a major area for baroreceptors. Reason being, of course, we want to make sure that we have high enough pressure to always be able to supply the brain. Another major location would be the aortic arch. Right in here, there's an aortic arch baroreceptor as well. And both of these pressure receptor locations will feed information of pressure to your medullary cardiovascular center. So any change, we could bring about changes that would affect our blood pressure. So again, I'm putting back our very important formula, so it's always kind of with us so that we always remember. Those blood pressure receptors, those baroreceptors, send signals to our medullary cardiovascular center as well as the hypothalamus medulla oblongata. That response is in terms of activating or the sympathetic or the parasympathetic nervous system, depending on what kind of change we need to make. Those areas can both adjust our cardiac output, they can adjust our resistance, they can adjust our heart rate to make sure that our blood pressure always stays in its perfect 120/80 millimeters of mercury balance. Try to remember that your body kind of prioritizes blood pressure first. And if blood pressure is prioritized first, we're going to make every kind of change that needs to be made in order to always homeostatically balance it. This is my favorite kind of sets of slides, and I hope that it really helps you. That formula can be used to make sure that you measure your blood pressure appropriately and know how we actually regulate blood pressure at all times. So using our formula, I wanted you to kind of run through these with me. Remember, blood pressure is prioritized. So if that changes, we're going to change the other parameters to try to make sure that our blood pressure stays even. So let's just say, if we're going to start on the left side of our formula, we see a change in blood pressure. So we either, in this case, we're seeing a high rise in blood pressure for some reason, we're seeing a low in blood pressure for some reason. If you start on the left side of the formula, there's a change in blood pressure, the immediate response of the body is to balance that. So if blood pressure in this case goes down for some reason, that our other two parameters are going to go up in order to homeostatically balance that blood pressure out. So we will raise cardiac output, we will raise resistance. Alternatively, if we started on the left and we had an increase in blood pressure for some reason, maybe you were exercising, you took a drug, something, the immediate response of the body is then to have to use those parameters to lower blood pressure. So cardiac output and resistance would both go down. Here's what's different. If for some reason we had parameter changes that were on the right side of the formula, on the right side of that equation, if they were on the right side of that formula, for example here, we had an increase in cardiac output. Well, the first thing you're going to do is, well, what's that going to do to my blood pressure? So the first thing you do is you see that if cardiac output goes up, that's going to make blood pressure go up. And if blood pressure goes up, then the body says, hey, we need to prioritize blood pressure. It went up. What should I do? It will lower the other parameter. You see resistance went down. Let's do that again, but we'll look down here. Just use a different parameter, different direction, but you can do this no matter what. Again, if you start on the left, if blood pressure goes up, both of these parameters would go down. But if we start on the right, either one of these parameters, let's say we're going to start with resistance this time. If resistance goes down, maybe something's happening, maybe you're vasodilating for some reason, and so the amount of resistance in your blood vessels are going down. That's going to cause your blood pressure to go down. And the body's like, what? My blood pressure is going down. How can I regulate that? It's going to cause the other parameter, you see cardiac output, to go up. These balance each other to balance your blood pressure. So this is an important way to use this formula. Again, if we start on the left with blood pressure, your two parameters simply balance blood pressure out. If blood pressure is up, both cardiac output and resistance will go down. But if we're starting on the right side of the formula, that's going to have an effect on your blood pressure that's going to be exactly the same. You see, exactly the same. And the other parameter will then be the homeostatic balance. If you use this, you will always be right in every time that you're trying to understand that regulation. Okay, let's make sure. So I wrote our formulas up here to make sure that we always have them. Blood pressure equals cardiac output times resistance. Cardiac output equals stroke volume times heart rate. Two important things to remember. So no matter what parameter we're increasing or decreasing, that's going to have an effect on our blood pressure. So these are all the factors that could affect our blood pressure. Blood volume. Well, imagine that your blood volume goes up for some reason. If blood volume goes up, that means that there's more blood inside of a vessel. So that's going to increase your resistance. And we know that if we increase resistance, that's going to have a direct effect on blood pressure. Blood pressure will go up. We know heart rate directly affects blood pressure. So if heart rate goes up, cardiac output goes up. If cardiac output goes up, blood pressure goes up. Same way if it goes down. If heart rate goes down, cardiac output goes down. If cardiac output goes down, blood pressure goes down. What would happen to resistance? Did you say it goes up? You are right. Very good. And stroke volume as well, the same exact way that heart rate affected it. Increased stroke volume increases cardiac output, which increases blood pressure. If blood pressure goes up, resistance would go down. Remember, you can always use this little diagram when I'm not talking so fast, but to really show you how every different parameter is kind of interrelated. A couple more. We have about, let's see, about 18, 19 to look at, but that's okay. They're all pretty easy now that you have a good understanding. So, what is venous return? Venous return is the amount of blood that actually returns back to your heart. And so anything that would increase venous return or change venous return would have an effect on blood pressure. More blood, more venous return. Less blood, less venous return. So if you're bleeding, you would have less venous return. And less venous return, that's less resistance, that would lower your blood pressure. So, for example, I wrote here, anything that lowers venous return would lower the systemic blood pressure because cardiac output, as well as that resistance, goes down. That's a direct effect. Interestingly, there's something called Valsalva's maneuver. Valsalva's maneuver is that thing that you do when you're straining to go to the bathroom, have a bowel movement. You kind of push down on your abdomen, push down on your diaphragm, close your glottis, you're kind of bearing down, straining. What's happening is you are creating a huge back pressure in your thoracic cavity while you're doing this, which actually lowers your venous return. The venous return goes down so low that that actually lowers your cardiac output to a dangerous level. And if you had a heart condition, that would lower your blood pressure so much that it actually could make you pass out. There's actually been a number of people who've died trying to have a bowel movement. Only if they had a pre-existing heart condition though. So don't worry, straining, but do increase your fiber. Strength of myocardial contraction, well, sure. Anything that's going to increase contractility is going to increase your cardiac output. And if your cardiac output goes up, well, then that would make your blood pressure go up. So that definitely makes a lot of sense. We've mentioned already sympathetic. The sympathetic works with your medullary cardiovascular system. It also works, we've seen its effect on your blood vessel diameter. We know that your sympathetic nervous system would increase contractility. It increases heart rate, but it also increases the vasoconstriction to our core. So all of these things are going to increase your blood pressure. You may not see a dramatic rise because also remember, it does cause vasodilation to those peripheral muscles so that you can run away. And so that vasodilation at the periphery can balance your vasoconstriction at the core. So you actually don't see quite the peak when you're actually exercising dynamically in your blood pressure. If you were not exercising dynamically, if you were having a static exercise, maybe doing like, isometric contractions where you don't move, you just constrict, that you would see a higher rise in your blood pressure because it would all be sympathetic, but you wouldn't have that vasodilation to the peripheral muscles because you're not using them as much. So during that kind of sedentary exercise, you would actually have a higher blood pressure. We were mentioned already that the parasympathetic nervous system depresses our heart rate. It releases acetylcholine, which binds to those muscarinic receptors. Not only does it lower your heart rate, it also causes vasodilation to the core to make sure that we have blood flow to the digestive system, for example. So in two ways, it lowers your cardiac output, it lowers your heart rate, it also lowers your resistance. So parasympathetic is all going to be about lowering your blood pressure. Epinephrine, as a neurotransmitter or as a hormone, can be released during periods of stress, periods of exercise. We know that it's released from your adrenal medulla as well as our sympathetic nervous system neurons. All of that is all about the same responses as sympathetic. Epinephrine as a hormone or as a neurotransmitter is still sympathetic. And so going to be increasing your cardiac output, generalized vasoconstriction to our core, both of those increasing our blood pressure. We know thyroxine increases your heart rate. It increases the body cell's use of oxygen, increasing your metabolic rate. And we also know that also increases that effect of epinephrine and norepinephrine. So exactly the same response, increasing our blood pressure. These might be two that you did not know before, so I want to take a moment. Vasopressin we have mentioned. Vasopressin is just another name for the hormone antidiuretic hormone, or ADH. We know ADH is produced by our hypothalamus, and we know that its job is to help the body conserve water, to retain water from the urinary system. But you may not have known that vasopressin also causes generalized vasoconstriction. And so imagine increasing the amount of fluid, so that's going to increase your blood volume, it's going to increase your venous return. Also imagine vasoconstricting. Both of those things are going to increase blood pressure. So we can actually see a release of ADH when your blood pressure is very low. If you had low blood pressure, you would actually see quite a bit of ADH release because we need to conserve that water to help us to increase our blood pressure. So this is one that can really counteract a low blood pressure situation. Same exact way that we're going to use ADH, we'll use this renin-angiotensin system. Again, renin-angiotensin system is all about increasing our blood pressure. How can we do that? Especially if we're in a situation where, I don't know, something's happening, maybe you're bleeding, and our blood pressure is dropping. So what do? Well, the kidney will release a chemical, an enzyme called renin. And renin converts a plasma protein called angiotensinogen. It converts it into angiotensin 1. We have another enzyme that's released from your lungs called angiotensin converting enzyme, ACE. That converts angiotensin 1 into angiotensin 2. What does angiotensin 2 do? Well, It causes vasoconstriction, as well as it promotes the release of aldosterone. Aldosterone, we know, promotes sodium reabsorption, which also causes water to be reabsorbed. So in the same way that vasopressin increased our blood pressure by vasoconstricting and increasing water volume, so does the renin-angiotensin system. It activates aldosterone hormone to increase sodium and therefore water retention. Both of those are going to help us to increase blood pressure. So vasopressin, renin-angiotensin system really help us to raise that blood pressure. Other factors that can affect our blood pressure are the viscosity or the thickness of blood and how many blood vessels you have. So if blood is more viscous, think sludge rather than fluid moving through those vessels, that's going to have a lot more friction. It's going to be a lot more difficult to slide through those vessels. That's going to increase resistance, and by our formula, that increases blood pressure. So does length of blood vessels. And I mentioned that before. Oh, the more blood vessels you have, the more resistance. Well, why would you have more blood vessels? Excellent question. Weight gain. Now, the verdict is out, the exact numbers of capillary mileage you gained, but you do gain capillary mileage. In some cases I've seen for every pound of fat you add, that's another mile of capillaries you have to develop in order to serve that fat. I've also seen as many as 7 more miles to serve that fat. So if you gained 50 pounds, that's 50 more miles at least of blood vessel, and then 50 more miles of work that the heart has to push blood through it. That's a lot of work for the heart. If you've ever heard of someone losing weight and their blood pressure going down, or they get off their blood pressure medicine, that's because they no longer have to work that hard to supply all of that extra fat. So the good news is, if we can slim down, we can lower our blood pressure. The last few are just various chemicals that can affect our blood pressure, chemicals that the body releases. The first one we have is a chemical that's released by the endothelium of a blood vessel. Remember that endothelium is the slick inner lining of a blood vessel called tunica intima. Well, tunica intima can release a chemical called endothelin. Endothelin is a very powerful vasoconstrictor. Whenever blood flow through a vessel is very, very low, what it can do is it can vasoconstrict in that area. Think of the garden hose again. It can narrow the lumen, and that increases blood pressure to increase blood speed or flow through the vessel. Alternatively, there's a chemical called NO, or nitric oxide. This is also released by endothelial cells, but endothelial cells found specifically within those blood vessels again, response to high blood flow rate this time, not below low blood flow rate like we saw with endothelin. If the blood is moving too fast through those blood vessels, that endothelial cell will release nitric oxide to signal vasodilation. It signals acetylcholine as well to lower heart rate, to increase vasodilation. Bradykinin is a chemical that we've seen, hopefully, maybe you've seen it in the immune system with wound healing. This promotes vasodilation. Both of those things are going to help to lower blood pressure in a hyperemia situation. Thromboxane A you may have heard of before because this is used when we have vessel damage. If you are bruised, if you get cut, that vessel damage, the first thing that's going to happen, and those platelets in our blood that are going to help us to clot, they're going to go to the area of that vessel damage so that we don't lose too much blood. But platelets release that chemical called thromboxane A, which causes vasoconstriction. The vasoconstriction in this case prevents some blood to get to that area, but it increases blood pressure beyond the damaged site. So beyond the damaged site, you may have a high pressure, so you may see your blood pressure go up in damage, but it also prevents more blood from entering the area, so we don't lose too much blood before that damaged site. Prostaglandins are another chemical that we use in our immune system, part of wound healing. Prostaglandins also cause vasodilation. Vasodilation, remember, is going to help to decrease that resistance, and so can really decrease blood pressure. Okay. This last one, ANF, it's also called ANP. It can be called atrial natriuretic factor. It can also be called atrial natriuretic peptide, so don't be thrown if you see both. Your endothelial cells of your atria in the heart also can produce a hormone called ANF or ANP, atrial natriuretic factor. When blood pressure is high, maybe blood volume is very high, the blood pressure in that atria is very high, we're going to release this chemical to try to lower that pressure. What happens is ANF actually antagonizes or inhibits both aldosterone, both ADH, the renin-angiotensin system. They're all going to be antagonized or turned off by ANF. That's going to help us to lose sodium, lose water, vasodilate, so that we can lower that pressure back down. So the atria themselves know when blood pressure is high, when blood volume is high, and so they can actually release a chemical themselves to help us to lower that pressure. I wanted to finish just by showing you, I won't ask you pathological conditions, but I wanted to show you the pathological conditions when related to blood pressure. Blood pressure or hypertension. You can see here it would begin, you're pre-hypertensive about 120/139 and 80/89. 140/159, you are hypertensive. 160 or higher, you are hypertensive times 2 or stage 2. Anything higher than 180, that's a crisis situation. Now, why does that matter? What is it when your blood pressure is either too high, or in this case you can see hypotension, too low? When it's too low, the problems with that is we really worry so much about getting that blood to the brain. Ever stood up too fast when you're on the floor playing with your dog or your kid? You're on the floor and you get up real fast and things kind of get dizzy, you're a little black around the edges of your sight. That's called orthostatic hypotension, and that's simply because the blood that was going to your head when you stood up dropped due to gravity. So what's going to happen is those baroreceptors in your neck are going to cause vasoconstriction, so we shoot blood really fast up to our brain. So that thickness, that dizziness, that blackness goes away pretty quick. However, when you're older, like maybe me, when you're older, our blood vessels can't respond as fast to that baroreceptor intervention, and because arteriosclerosis is a natural progression. So when I'm on the floor playing with my dog and I stand up too fast, I get the same dizziness and the same blackness around the edges, but I might have to hold on to something for a good 30 seconds until my vasoconstriction can take place and until I can shoot that blood back up to my brain. So it takes a little longer as you get older. That's why a lot of elderly have that chair that helps them to get up really slowly so they don't get orthostatic hypotension. Okay. I like to mention hypertension simply because it's kind of called a silent killer. Most people who have high blood pressure don't even know because they don't feel bad. If you don't feel bad, then why would you do anything about it? When we have poor diet and we're overweight, as we get older, certain race, genetics, heredity, stress, and definitely smoking, all of these things are risk factors. But the problem with hypertension is it really causes a lot of problems over time. Hypertension can eventually cause what we call stroke, transient ischemic attacks, tiny little ruptures in the capillaries of our brain. It can increase the amount of sugar in your blood. It can actually cause ruptures in the blood vessels, capillaries of your retinas. It can cause ruptures in the capillaries of our nephrons. Over time, one of the first things you're going to see, and this is over time, like 10 years of being hypertensive, your kidneys begin to fail because you have had so much pressure on those tiny capillaries for so long that they are going to rupture, and that rupture damage will eventually accumulate. And so a lot of times people don't get their, for example, the diabetes mellitus checked. They don't get their hypertension checked. They don't take their medicine. They don't take care of themselves because they feel fine. But just remember, this is a chronic problem, and the damage that's tiny accumulates. So you have to take care of yourself now so that in 10 years or 20 years, you're going to be great and you're going to be running around the block with your dog. All right. Well, that's the last bit of information before our second exam. And so I hope you have great luck, and let me know if you have any questions.